we've been talking about bispecifics. We talked a little bit about CAR T therapy in the treatment of follicular lymphomas and how exciting the space is. But as you recall, at the late breaking abstract session was the combination of tafasitamab with rituximab and lenalidomide. So tafasitamab R squared, the same theme that we've talked about as second line therapy for patients who relapse with follicular lymphoma. And that the results of that did show that there was a significant improvement in PFS with that combination compared to R squared alone. And I'd like to hear you all's take on it. So, Dr. Chavez, how excited were you about that data, and what do you think about that data?
I honestly think that it's always good to see a positive study, especially focusing on high-risk follicular lymphoma. As soon as the study was presented, the immediate reaction was to compare this study to Augment, especially the PFS in the R square arm and the control arm. That actually the PFS in the R square arm was much better than in the INMIND. However, there were some differences, especially in the patient population. The patient population, the INMIND, they didn't discriminate whether the patient was rituximab refractory or not, whether in the Augment, rituximab refractory patients were excluded. However, when they did the subgroup analysis, still, I saw a little bit lower responses even in the non-rituximab refractory patients. So there was a benefit in PFS, no overall survival. The follow-up is still short. I think it's always good to have a good option. I think we need a longer follow-up. Personally, I think that I personally not using it. I don't think I'm going to do anything different based on the data that was presented. But it's always good to see a trial, the effort of the investigators to carry on a trial in a difficult patient population. So, and then the other thing is probably a little bit the scheduling. Tafasitamab could be a little bit complicated, every week and then every other week, and then that can be a little bit tough for patients. So, but we're not going to have a study that is going to change the regimen, but we just have to kind of make the decision based on patient characteristics and also patient wishes. Is it something that you want to do, or is it something that you prefer to stick with R square and see what happens in the future?
Now, what do you think about the fact that the study did not show increased adverse reactions with the triplet? It appears that the triplet was just as I don't want to say just as toxic, but the toxicity profile of the triplet was not anything surprising when compared to the doublet of R squared. What do you think about that?
So I'll jump in because I let Julio do all the heavy lifting for the initial discussion of the INMIND trial, and I'll agree with everything he said. The result was, provocative, pleasing, maybe not practice changing insofar as at the end the efficacy was moderately better, significantly but moderately better than the control group. And it was showing response rates in mid 80%. Whereas we have these early trials of other R squared combos like the bispecifics, who are seeing response rates at above 95%. So promising, but maybe not practice changing. Maybe with more follow up it could be, but not so far. The question of its tolerability, yeah, I agree completely. It was pretty well tolerated therapy. It's not so surprising. Tafasitamab is a very gentle and well tolerated agent. I mean, the main toxicity, I would say, from my patient's perspective of tafasitamab is exactly what Julio said. The frequent trips to the doctor is the toxicity. and that's, a hassle, but, not as bad as high-grade infections and so forth. So, I mean, it's a plain old naked monoclonal antibody against CD19. Not surprising that it's pretty well tolerated, and it was. So I think there might be a certain type of patient who is just the right patient for tafasitamab plus R squared, like in the INMAB trial, in the INMIND trial. Maybe the more comorbid older patients who you'd worry about, or even if they had very low ejection fractions, you worry about any cytokine release syndrome or something like that. That's maybe a rare patient, but they exist. And so maybe that would be the right patient for this pretty gentle approach of TAFA plus R squared.
Wow. So, it seemed like you're reading my mind, because the next question I'm going to ask you is a very important question, in the sense that as these new therapies begin to emerge and they become potentially available to us in the clinic, what and how do we position these agents in the initial treatment of patients? What's our first line potentially? So let's imagine a world where all of these agents are available. What will be your first line? What will be your second line? When would you use CAR T in a patient with follicular lymphoma?
We're very lucky in follicular lymphoma this is what we say, a good problem to have so many great options. And, I think all of us here were doing this, 10 and 20 years ago when we did not have all these great options. We had patients that got chemo and that was that. And now we have so many more things. These targeted therapies, immunomodulatory therapies. It's like a very pleasant time to be a doctor taking care of these patients because we've got a lot of good things. This is a space in which I think the patient's life and feelings about the options is relevant because, if a patient has aggressive frontline DLBCL, I don't necessarily give them a lot of choice. They need to get this chemo, period. There's not, how they feel about it. Here in follicular lymphoma, we have chemo, we have, immunomodulators like IMiDs, like lenalidomide. There are probably other IMiDs coming down the pike as well. And then these strong immunotherapies like bispecific antibodies. And patients can have an opinion about it. And if they say, I do not want chemo, period, great. We're going to give you R squared plus a bispecific once it eventually gets FDA approved for the frontline. That's still a little ways away. And they're going to have long, durable remissions, the great majority of them. And if they say, I have patients who say, I had a friend with myeloma who was taking Revlimid and he hated it. I don't ever want that pill. Fine. Those patients can still get great efficacy with Arbenda or other alternatives, or even probably will have bispecifics as monotherapy for as an option for even for frontline follicular lymphoma in the not too distant future. And although Julio and I both agreed that combo with bispecifics is probably the best, we still have great response rates and pretty good looking durability with monotherapy as well. So this is a space, frontline FL, where patients are going to have some choice. And then what is the second line therapy for them? As with all these things, it depends what they got in the front line, how well they tolerated it, and how long their remission was. And if they got, just to pick, again, what I said might be my preferred regimen, R squared plus a bispecific antibody, if they got a 6-year remission, they can get some of those ingredients again. They can certainly get bispecific again as a monotherapy if and when they relapse. And the only caveat there is those patients probably need biopsies at the time of relapse to make sure they didn't have this antigen escape problem, the loss of the target, the loss of CD20, because it can happen, and we don't want to be treating with a targeted agent if the target's not still there. But I think those will be a common first and second line treatment approaches for FL in the near future.
So what of CAR T? Where does CAR T fit in all of this?
CAR T actually, we kind of skip a little of the data was presented at ASH. We had the 5-year SUMA-5. Looks very good. PFS 60 months with high-risk patients, vast majority POD24, rituximab refractory, len refractory, even PI3K, when we had PI3K at the time. So I think CAR T cell therapy has a role in follicular. And I usually recommend for patients with high-risk features, or those patients who relapse with, high tumor burden, or those who relapse with, POD24, like an early relapse from frontline, or poor genetics. We have still the follicular lymphoma that are P53 or complex genetics. So I think there is a role for CAR T, and that's my preference in the third line. For other patients that are more like a less aggressive disease, like a no POD24, probably those patients, my preference is a bispecific antibody. Even though bispecific also work very well in high-risk patients. However, I had a discussion with the patient, and I kind of present the pros and cons. CAR T cell therapy, even though it's a one-time treatment, however, it requires like a monitoring, being in the center, and probably unable to drive for 2 months, depending on what CAR T product you use. So there are some nuances with CAR T cell therapy too. But it's a one-time treatment, and then after that, then there is no treatment. It's just kind of like a surveillance and monitoring. And however, CAR T cell therapy comes with other things. Secondary malignancy is something that has been described recently, and it has to do with the number of lines of therapy that patients have received consistently in meta-analysis. So I try, when in the discussion with patients, I incorporate CAR T cell therapy, but I also mention the pros and cons of CAR T versus bispecifics, including the efficacy. So I think as a single agent, my honest opinion is probably CAR T is better in terms of PFS. However, there is more promise with combinations with bispecific antibodies that it may actually even trump or even may equal the efficacy of CAR T-cell therapies. So that's what I'm looking forward, see how the combination with bispecifics in follicular lymphoma show in the future, so we can have a better kind of a decision for patients.
So we just talked about CAR Ts, we've talked about tafasitamab, and we talked a lot about epcoritamab. But I want to talk about some of the other bispecifics that are either approved or have emerging data that are in the later stage of development. And I think the two that I would think of the most would be mosunetuzumab and odronextamab. So, Dr. Chavez, I'll start with you. Tell me what you think about Mosun and its role in the treatment of follicular lymphomas, and how do you choose which of these bispecifics as your favorite?
Yeah, Mosun, as you know, is the first bispecific that was approved for follicular lymphoma. Great efficacy, a decent progression-free survival for high-risk patients, kind of CAR T-cell population. So I think it's a great option. And the nice thing about mosunetuzumab is that it's fully outpatient. So, and also the toxicities are manageable too. Majority like a CRS is grade 1 at most, maybe a little some of grade 2. It's a time-limited option, especially during CR. After 8 cycles, you're done. During PR, up to 17 cycles. And the retreatment data looks pretty decent too. So I think I pointed out what Dr. Brody mentioned, that you can actually use these drugs again. You have a decent response. So you have the median PFS with mosunetuzumab is between 24 to 27 months. So after 2 years, you relapse. I don't think there's a good reason to kind of consider retreatment on those patients. Also, mosunetuzumab, as I mentioned earlier, is that has good data in the frontline setting. There is actually good data with mosunetuzumab subcutaneous. Mosunetuzumab is intravenously. Now we have subcutaneous that has less actually cytokine release syndrome rates. So I think that's some of the advantages of mosunetuzumab. For odronextamab, I have very little experience, to be honest, in clinical trials, but based on the data that was presented, I think one of the problems with odronextamab, it has a great efficacy, great CR rate, and also a good duration of response and PFS, similar to actually Mosun. However, the scheduling is a little problematic to me, especially when you do 2 days in a row infusions on a weekly basis to get to the full dose. That may be a little problematic in the community, or how to do that in community centers or even in academic centers, when you have to kind of have the patient twice, same day, looking for lodging. And so that may be a problem. I know they have CRS, they have a little higher grade CRS. That's why they developed this scheduling. And that actually was safer, to be honest. But I think the scheduling will be a problem. And it's not any better than other bispecifics. So I think the decision will come to the logistics at some point.
So it's good to have choices, right, Dr. Brody?
Absolutely good to have choices. And, I think Julio expressed them very well for these FL patients. And again, it's a good problem to have some options. Overall, I think these, as Julio was saying, these things are medically more similar than different, and logistics are the difference. And right now, today, here we're speaking in February 2025, the main difference logistically between Mosun and epcoritamab for FL is today Mosun is an intravenous therapy that could change one day in the future, and it's time limited, whereas Epcor is a subcutaneous injection, and we say dose until progression. And some people just, the patients, the doctors as well, but the patients may just have preference for one path versus the other there.
So talking about this treatment till disease progression, what have you done with your patient who's treated with epcoritamab, who is in CR, and 3 months into it, and they say, Doc, I just want to take a break? What have you done in your personal practice?
I'll give my experience, this anecdotal. I have really both settings, and this is true for FL and aggressive lymphomas as well. I have patients who are early on and want a break. I also have patients who are long gone. They're 20, 24 months on therapy. They've been in complete remission for, a year and a half. And I say, you know what? the recipe says keep going once a month, and it's a quick trip, and you don't seem to mind, and you have no side effects, so you can. Or if you want to, it's your call. If you want to take a break, we can take a break. And I have patients that said both to me, oh yes, please give me a break. And I've had patients that say no. Last time I took a break on some other prior line of therapy, I thought I was going to stay in remission, and I relapsed. I want to keep going. And I'm even sometimes surprised. But if they're tolerating it well, if it's once a month sub-Q injection, I guess I shouldn't be that surprised that some patients have chosen to just keep going. So I've seen both answers, and I think they're both reasonable. We don't have high-level data to say, treatment holidays and so forth, what's the up or the down of it. And we do think that we can retreat patients if they're still CD20 positive and were to relapse. So I think it's another place where patient preference can have a role.
So you seem to like the flexibility then.
Overall, I do. I mean, again, it's a good problem to have flexible options. So yeah.
I've seen the same thing with patients. They want sometimes a break. We explain that we don't have a lot of data. I would say majority of patients stick with the plan of continuous therapy. However, some patients really want to have a break, and I have patients that are from India. They kind of went to India for a couple of months, and they came back and they restarted again. As long as it's not for too long, like 3 months, that you have to do a step up again. So if it's no more than 2 months, I kind of tell the patient, you're going to spend back home in your country for a month or 2 months, that's fine, and then we'll see you back, and then restart again based on make sure that disease is not back, or so we do a scan just to make sure that there is no active disease. But I mean, some patients ask, we offer some kind of strategies. There is no uniform strategy, but my experience is majority of patients want to stick with the schedule.
So I'd like to get some closing thoughts from you guys. So ASH 24 is passed. I know we're all excited. Maybe some of us are thinking about EHA, but planning for ASH 25, it's never too early to start planning. So what are you excited about in follicular lymphoma in the year to come? I'll start with Dr. Chavez.
I think I'm excited to see more real life experience now that we have 2 bispecific or 3 bispecific products for lymphomas. Not only in follicular, but also the LBCL, looking at treatment patterns and management of toxicity patterns that, whenever I speak to my colleagues in other centers, they do a little different things that I'm trying to copy a little bit in order to improve patients' outcomes and satisfaction. Like, for instance, treating CRS grade 1, like Dr. Brody mentioned. So, without admitting the patient. So we're doing that too. And I know other centers doing it. I think real life experience is something I'd like to see more.
And to finish up here, Dr. Brody. So tell us, what are you excited about?
Agree completely with that, with everything that Julio said, and real life data will be exciting to see. And we still have more combinations and new innovations to try. Combinations with other therapies, EZH2 inhibitors, other targeted therapies, newer IMiDs, golcamide rather than lenalidomide, and also, new bispecifics, CD19 by CD3 bispecifics, as well as trispecifics and even tetraspecifics in ongoing trials. So a lot of cool innovations to kind of build on the progress we've made in these last couple of years.
Thank you so much. And I'd like to thank you, too, for being so erudite and giving us a very robust conversation today. And we look forward to seeing you again and having another conversation in the next few months. Thank you so much.